Hi, this is Kay, a psychologist and human sexuality researcher, and today I'd like to talk about sexual dysfunctions. So let's start. There's a lot of discussion surrounding mental health and physical health. And the World Health Organization recently recognized mental health as the fifth core element of global health policy. And this acknowledgement signifies that mental health is now considered as significant as non-communicable disease, such as cardiovascular disease or diabetes or even cancer. However, amid the discourse on mental health, sexual health often remains neglected. So there's a lack of conversation about the prevalence of sexual dysfunctions and advancements in therapies related to human sexuality. And given my specialization in human sexuality, in this episode I aim to shed some light on how prevalent it is. And you might be actually surprised by how prevalent it is. I mean, how prevalent sexual disorders are. And I will also discuss the most common dysfunctions and explore therapeutic approaches. But first and foremost, I want to emphasize that I want to just give it a crucial point. So if you turn off this episode right here, I want you to remember that sexual dysfunctions are diagnosed when they cause distress to an individual. So there are no standardized measurements dictating how much sexual intercourse one should have, or how many partners they should engage with, or what specific sexual activities they should participate in. So for some, minimal sexual activity is entirely satisfactory, while for others, more frequent encounters are desired. And well, as long as this frequency does not pose a problem or distress to the individual, there's no need for diagnosis of dysfunction. So there's no need to consult your situation with the specialist. However, if anything related to your sexual life bothers you, it's advisable to seek medical advice, or at least to consult it with a therapist or someone with therapeutic background, at least. And sometimes the issue may simply stem from a lack of understanding or misinformation. So for instance, it's quite common for young men to express concerns about maintaining an erection for an extended period, and it is often influenced by unrealistic portrayals in porn movies. So the porn movies is usually if you watch the porn movie, the man can have sex anytime, everywhere, with everyone for hours, which is obviously not true. So education from a healthcare professional can alleviate such concerns. And similarly, some individuals may feel troubled by their sexual fantasies. And I remember one client who thought their fantasies are kinky or queer. So if they perceive them as unconventional, seeking guidance and information from a doctor or from a therapist can help alleviate these worries. And additionally, individuals with more severe sexual dysfunctions, such as inability to engage in sexual activity or experiencing pain during intercourse, they should not hesitate to seek professional help, because you should remember that sexual health is just as important as any other aspect of well-being, and there's no reason to feel ashamed or embarrassed. And addressing concerns promptly is crucial, and as delaying treatment may just exacerbate the issue. So therefore, if you ever feel that something isn't right, or if you're unsure about your sexual health, just please don't hesitate to schedule an appointment with your doctor and just be open and honest about your concerns, and I'm sure they will be able to help you. So, well, assessing the prevalence of sexual dysfunction isn't straightforward like diagnosing cancer or diabetes through, for example, laboratory tests. With sexual dysfunction, individuals must actively seek medical attention, and, well, not many do, as you can imagine. However, there are some research conducted on quite representative samples in the United States provides some insights. And the research suggests that approximately 43% of women, so 43% of women, and 31% of men experience some form of sexual dysfunction. It also highlights a disparity between genders, but I'm repeating it once again. 43% of women, so just 7% less than half, and 31, so 1 in 3 men experience some form of sexual dysfunction. It's a lot. It's really a lot. And interestingly, studies on sexual dysfunction prevalence among men who have sex with men reveal even higher rates. It's not clear how much higher, because usually, unfortunately, research conducted on men who have sex with men are based on non-representative sample. But anyway, research estimate that between 42 to 79% of men who have sex with men experience some form of sexual dysfunction. And this underscores the significant impact of biological and psychosocial factors on sexual health. And it is crucial to understand that sexual dysfunctions aren't solely influenced by biology or physiology. They're also intertwined with mental health and various socioeconomic factors. And for instance, gay and bisexual individuals may experience higher levels of chronic stress, or contributing to the prevalence of sexual dysfunction. But it is, of course, the subject of research, so it's not yet absolutely clear, but this is one of the hypotheses that can explain a higher range of sexual dysfunctions among non-heterosexual men. And regarding women, especially women in same-sex relationships, there's limited literature available, but from research that are available, it is estimated that sexual dysfunction affect approximately 10 to 20% of women who have sex with women, which is primarily bisexual and homosexual women. So this means that approximately 1 in 5 of these women may experience some form of sexual dysfunction. And these findings highlight the complex interplay of biological and psychological and social factors in sexual health. And I guess and I believe that understanding these nuances is quite essential for addressing and managing sexual dysfunctions effectively by both medical experts, psychologists, and therapists. And there are notable differences in sexual dysfunctions and their diagnostic criteria between men and women, as outlined in the official psychiatric manuals. However, it is crucial to understand that this is not a one-size-fits-all scenario. So in the diagnostic process, numerous factors must be considered, including individual's life situation, the gender of the partner, the own gender of the person, sexual preferences, lifestyle, and more. So each case is highly individualized, yet these individual nuances are described in psychiatric diagnostics manuals such as DSM or ICD. It is, of course, a very general description, but somehow psychiatrists must put all these individual aspects into some kind of manual. So in the DSM-5, sexual dysfunctions are defined as a clinically significant disturbance in a person's ability to respond sexually or to experience sexual pleasure. And importantly, if there isn't considerable distress, it doesn't qualify as a diagnosis. And this distinction is vital because nobody should feel pressured into sexual activity. So for some individuals, abstaining from sexual behavior might be less distressing than engaging in it, and it's totally okay. And it's essential to recognize that certain individuals may experience low sexual arousal or desire without feeling bothered by it, and it's fine. And these nuances must be carefully analyzed by specialists if the client shows up at your office. And the DSM, so the American Manual for Mental Disorder, delineates 9 types of sexual dysfunctions, and 4 of these pertain to typical male dysfunctions, 3 are related to women, and the remaining 2 describe substance or medication-induced dysfunctions and sexual dysfunction that do not meet the full criteria for any of the other disorders. So for the purpose of today's episode, I will focus on the most significant groups, so I will skip these 2 remaining groups, such as substance-induced dysfunctions and other dysfunctions. So let's begin with women. The first category of female sexual dysfunctions is sexual interest or sexual arousal disorder. It is characterized by a complete lack of or significant reduction in sexual interest or arousal. And diagnosis requires the manifestation of 3 or more symptoms, including an absence of interest in sexual activity, reduced interest, and lack of sexual or erotic thoughts. However, it is crucial to note that this must be accompanied by individual distress. So again, I underline it that this person must feel distressed or bothered by lower sexual interest or lower arousal. If it doesn't bother you, there's no cause for concern. But there's one more thing I have to mention, that comparing your sexuality with others can lead to psychological distress, and it is completely unproductive. So please do not compare frequency of your sexual intercourse or quality of your sexual intercourse with other people. And various factors may contribute to this disorder, with stress and relationship troubles being common triggers. So relationship issues often manifest alongside sexual problems, as dissatisfaction or conflicts can impact arousal and interest. So therapy involves careful analysis and may include observing patterns during sexual activity to identify the triggers. The second significant group is female orgasmic disorder. It is characterized by a notable change in orgasm, such as delay, reduced intensity, or cessation. And changes in sexual experience, such as difficulty achieving orgasm with a new partner compared to a previous one, warrant consideration. And therapists may explore potential triggers, such as recent changes in life or relationship dynamics, including infidelity, for example, which can impact orgasmic response. And these factors require careful examination during therapy to identify underlying causes. Sometimes the underlying causes are easy to spot, sometimes they are hidden deeper, so it requires some time, but over the course of therapy, they should be identified and addressed properly. And the final group of sexual dysfunction in women is genitopelvic pain or penetration disorder. It's characterized by difficulty having intercourse and experiencing significant pain upon penetration. And it is essential to note that this isn't diagnosed after the first sexual encounter, as initial discomfort is quite common. So instead, diagnosis occurs when pain is consistently felt during penetration by a partner or by an object. And therapists should inquire about pain during various forms of penetration, so as the source of discomfort may vary. So pain during specific types of penetration, such as with a partner's penis, but not with other objects, may indicate psychological factors. So there might be something with, for example, fear of getting pregnant. It's just, I'm just throwing it off the cuffs, but this is common things that occur during therapy. So if a woman is if the woman is afraid of getting pregnant, sexual intercourse with partner's penis might cause pain, but not she doesn't feel pain while being penetrated with an object or with finger and so on. For example, this might be one problem, and conversely, consistent pain, regardless of the penetrative object, may have physiological origins, such as infection or some kind of anatomical issues. So this all must be analyzed. And when it comes to men, the most common sexual dysfunction is, of course, erectile disorder, and it is characterized by the recurrent inability to achieve or maintain an adequate erection during partnered sexual activities. And it's important to note that if you can achieve an erection through masturbation, but struggle during partner interactions, you may be diagnosed with erectile disorder. So, as you can see, there is some kind of psychological issue in the background, because if you have trouble achieving erection while being alone, if you have trouble achieving erection while being with a partner but not while being alone, it means that, for example, you are afraid of, I don't know, being assessed by a partner, or something that you might fear that you are not enough, you're not good enough, and that's why you have problems with achieving erection. Or, for example, the way you are having sex is, for example, not enough stimulation for you. So, for example, if your partner put more strength into your sexual contact, it might be better. So this is also all to analyze. And the second and third group of disorders are delayed ejaculation and premature ejaculation. And delayed ejaculation refers to a persistent difficulty or inability to achieve orgasm despite adequate desire, arousal, and stimulation. And premature ejaculation involves a persistent and recurrent pattern of ejaculation within about 1 minute following vaginal penetration, occurring before the individual desires. So for delayed ejaculation to be diagnosed, the difficulty must be first persistent, so it's not just a one-time occurrence. And therapists may inquire about consistency with the same partner to assess the disorder's persistence. So, for example, if you had this problem with your previous partner and you had this problem with your current partner, so yes, this is definitely an issue for psychologists, for therapists. But if you, for example, if you've never had this problem and you have it right now, so this might be related to, for example, medical treatment or substance or stress and so on. And when it comes to therapy, if you feel pain, so if you have difficulty achieving orgasm and you also feel pain or discomfort, you should definitely see a doctor, because this might be related to not always serious, but it might indicate some serious medical condition. So you should definitely seek for medical help. And conversely, premature ejaculation must also be persistent or recurrent and occurring within about 1 minute following vaginal penetration. So while this definition mentions vaginal penetration, it can apply to penetrative sex in general. So if you have a male partner, you can be diagnosed with premature ejaculation as well. And it is worth noting that premature ejaculation may occur in young men starting their sexual lives. And usually it is nothing to be bothered about, because this can happen. But if it persists beyond initial experiences, consultation with a specialist is definitely advisable. And the final group of male disorders is male hypoactive sexual desire disorder. It is characterized by persistent or recurrent deficiency in sexual or erotic thoughts, fantasies, and desire for sexual activity. So, diagnosis requires these symptoms to be accompanied by psychological distress, and if you are content with your level of sexual desire and you do not experience distress, there is no need for treatment. And I'm mentioning it once again. If you are okay with the level of your sexual desire, you should not be bothered by diagnosis of hypoactive sexual desire disorder. So don't worry. But if it bothers you and you wish you were more sexually active, and you wish you had more desire or higher level of desire, then you can visit the doctor and discuss this with them. Okay, so now, when it comes to interventions for sexual disorders, there are diverse interventions, and all of them can target specific issues, and of course, the root causes of disorders. And the most common approaches include psychotherapy or counseling, of course, and it might be individual therapy or it might be couples therapy, sure. And over the sessions, you would probably explore psychological factors contributing to sexual difficulties. Maybe you can address your relationship concerns, and most commonly you will develop coping strategies. So, for example, different forms of sexual activity, or maybe the professional sexual counselor will help you to develop some different patterns that are better for you. And of course, intervention can include medication. So, for example, antidepressants, hormonal therapy, or drugs targeting specific dysfunctions are definitely effective in alleviating symptoms. Sometimes, as I mentioned earlier, the education and communication might be an issue. So, providing information on sexual health, anatomy, and functioning can improve your ability to achieve orgasm, and can reduce your anxiety and pain. And of course, improving communication skills within a relationship, it also enhances sexual satisfaction. And other interventions may include behavioral interventions, just like behavioral exercise, that techniques like sensate focus or systematic desensitization to help increase comfort and reduce anxiety. And of course, lifestyle changes, so addressing stress, substance abuse, or poor diet, it can also positively affect sexual functioning. And very rarely, but sometimes it can happen, that procedures like penile implants or corrective surgery might be necessary for addressing the physical causes of dysfunctions, but this is very, very rarely. So please do not worry about it in advance. It's very unlikely that this is your problem. So, in summary, sexual dysfunctions encompass a broad range of issues that affect individuals' ability to engage in satisfying sexual activity. And these dysfunctions can arise from various factors, including psychological, physiological, or relational aspects. And seeking timely intervention and support well tailored to individual needs is essential for addressing these challenges. And if you find a good therapist, or not even a therapist, but if you find an educated and well communicating medical doctor, I'm sure they will be able to restore sexual well-being. And I guess that's all I wanted to tell you today about sexual dysfunctions. So I hope you found it interesting. Now, thank you for listening, and until next time, bye.